produces it, only affects the keratinocyte. So this would be a way that you could target IL-22, get rid of the skin disease, and only affect in the skin. And investigators are looking at that today. And what we do know as a group, so this is the good thing that we tell our patients, is if we look at all the agents we have today, regardless of the biologic, and sorry for that little typo, if we give a patient any of the existing biologics today, we see total reversal of the psoriatic plaque, you see decrease in expression of keratin 16, normalization of the skin. If Dr. Van Voorhees did a nice study where they looked at systemic inflammation. So they did MRIs of patients who had psoriasis, and they looked at just whether or not they were treated. These are untreated patients, actually. And you'll see hot spots of inflammation. You'll see it in the liver. You'll see it along the aorta. You can even see it in some of the blood vessels, and you see it in the skin. So there's systemic inflammation going on. So psoriasis is probably not just a skin disease. I like to refer to it as a systemic skin disease. You give that same patient a biologic, all that inflammation goes away. So if systemic inflammation is contributing not only to the pathogenesis of psoriasis, but possibly to some of the comorbidities we see in it, then I think that one of the next phases we're going to be looking at is, does the biologic that we use to clear the skin help with systemic inflammation? And we don't know that. Intuitively, we would think it would, but we don't have that data yet. So what do the biologics do? They basically target the inflammatory cytokines that contribute to inflammation, contribute to clinical disease, contribute to joint damage, and overall decrease the inflammation. So we have a ton of medicines that we can use. How do you pick which one to use? Well, in our country, I think first and foremost, insurance is the issue because these drugs are ridiculously expensive. So you have to make sure that patients can get them. Prior therapies help. What do people respond to in the past? They might respond to again. We don't need to look at classes and say that they must have an anti-TNF or an anti-IL-12, but it does help because we know that in joint disease, TNF is a bigger player than IL-12/23, so intuitively the anti-TNFs may be better for joint disease than non-TNF mediators. But we don't know that. So all of those things come into play. So again, we look at what they've used. What we need, though, in the future is if there was some sort of assay that we could take a patient that looks like this and see what his genome is expressing or see what cytokines are elevated, not unlike you measuring, your IL-6. So if we could see in that individual patient what is the predominant cytokine that's driving psoriasis, then you could have a better tool to pick which drug would be your better agent. And we don't have these assays yet. But that, I think, is something that we really need, is how do we tell which patient will benefit best, and that will make it the most cost effective because you don't have to go through trial and error. The other thing we would like to find is there a particular marker that can identify a person who would respond to one drug versus the other? Does phenotype really correlate with genotype? We don't know that, but maybe looking at gene arrays might help us in determining that. We know we've come a long way. In the old days, we had tar. Today, we still have tar. We've had a number of toxic agents that we used for psoriasis. We had a lot of cytotoxic agents that we used, so systemic agents that kill everything, including the psoriasis plaque. Then we got a little bit more sophisticated and started targeting the individual cytokines, and so there's potential ways to target those cytokines. And these are the 4 potential ways, and we've done most of them. We first started with targeting the T-cell activation itself. That wasn't a good result in the end because it shuts off the whole immune response. So then we started looking at, well, the activated T cell produces cytokines. We can target those. Not as bad, but not really super selective. So then we could go get more super selective and look at the individual cytokines that are being produced and block those. Or today, we're trying to looking at what is their counter-offensive therapy. So how can we prevent it from happening? And so I think what we're looking at for the future is we want to really still home in on the pathogenesis because it's not solidified yet. We need new research that will allow us to pick treatments based on evidence instead of trial or error, which will save money for the system. We want to target those genes in maybe that individual that's causing the problems. And so we need to focus on treatments, I think, that are going to be tailored to the individual patient with psoriasis, not to the class of disease itself. And I think with that, I will end. Thank you.
Any questions? Yes.
Not appearing on. It's here, but it's not there. Okay. Well, we'll finish our session. I'm going to go over in therapy, adverse drug encounters are increasing, and we have very sophisticated tools that we can use, and we're just beginning to understand a lot of this. And as I mentioned early on, I was doing lymphocyte transformation. That was 1970, and it had never reached mainstream. In Europe, probably understandable because they were much more courageous. My colleagues in Scandinavia, they would bring patients in and challenge them to find out the causative drug. The lawyers in the U.S. would love to have us do that, but it's not to be. So we have to find other means so that we take the patient out of the risk factor. I have no conflicts of interest. I've just retired, and so I don't have to deal with pharmaceutical companies and their outrageously expensive medications and trying to find the right path for my patients. We've seen our concepts evolve, and as we understand better the metabolism, the function, drug interactions are getting to be an extremely important thing, so that when we're called on to see a patient who has, and most often either something's going to be picked up on the chem profile, liver function or something, or more often the skin. It stares right back at you, and if they're blistering and dying from all their skin, like a third-degree burn, that gets one's attention. So we have a lot of interactions. The immunologic ones are important. We'll talk about that because we generally assume, but don't ever want to test it, that someone who's developed a bona fide, especially IgE-mediated immunologic reaction, re-exposure could result in anaphylaxis and death. On the other hand, we have drugs. Most of my career has started with looking at patients with reactions to dapsone, my first paper, and we found during Vietnam dapsone was an antimalarial, and we had a number of military from Vietnam in hospitals in Japan with the dapsone reaction of one type or another, and what happened was there were a number of patients who were discharged and restarted on dapsone, and most of them survived. So there's a lot of things we don't know about these types of reactions. And we're learning more about metabolism, the acetylators, and the biologicals are something else. But the biggest problem is polypharmacy. When we first started a clinic at the VA in Biloxi, which is just down the coast, the VA at that time, the veterans would come in with a computer printout of the medicines are on. Some of them, the piece of paper was this tall, and as with most governmental things, there's never enough, as the old saying goes, There's never enough time to do it right, but you can always find time to do it all over again. So polypharmacy is a real contributor. We've talked about these. The other thing, as we understand better with medications, is how it's distributed, what proteins carry it, competing proteins, and things like this. And then also, we've learned an awful lot about interactions, drug levels, and drug interactions related to the cytochrome system, which we'll talk about in a minute. So it was mentioned earlier about cytochrome 3A4, which is one of the very interesting ones involved in metabolism, because so many drugs are involved with this, and certainly some of the most popular drugs. Here you see some of these. Inducers accelerate the metabolism, so the blood levels go down. That's good, maybe, unless the patient needs that medicine metabolically. And we see it affecting steroids. We see it affecting anti-epilepsy drugs, nafcillin, and even St. John's wort, which has become fairly popular. I have a plant of that in my yard. It's quite pretty this time of year. The inhibitors, grapefruit, used to be the universal morning drink, and grapefruit juice can create problems in maintaining therapeutic levels, because it will slow the metabolism, and you can get toxic levels. And perhaps before the biologicals came around, we were in this war of the toenail fungus, where the imidazoles were proliferating, and again, drug interactions. Erythromycin and the other macrolides, a problem. HIV antivirals, and amiodarone. So we have to be aware of this when all of a sudden, this is Katrina, which changed Aaron and my life very extensively as it came ashore. Similarly, we can see this happen, as was mentioned earlier, in acute drug eruptions on a hospitalized patient. Patient in 24, 48 hours can start going with a pemphigus or burn type picture and end up being in the intensive care. And we also need to be aware in general of gender. And those studies were done originally in the NZB, NZW mice, where you look at collagen vascular disease, and you could accelerate or slow this process by adding estrogens or androgens. The old system was the Coombs and Gell, and this is it here. The significant one, usually, for dermatologists is either type 1 or type 4. And type 1, of course, is most significant because, as I mentioned earlier, one can get re-exposure, anaphylaxis, and not survive the situation. Types 2 and 3 are still being worked out, but they're less life-threatening. That's changed. Things have evolved, and all of these situations in Aaron's talk, inflammatory mediators, is that part of the immune system? Yes, maybe, maybe not. But as people like to separate, whoops. Let's see, here we go. Toll-like receptors. that was something 12, 15 years ago was unheard of. And now that's got to be a very big thing. And then some of the other cytokines. Of course, one of the common and sometimes difficult to prove signs and symptoms of an adverse reaction is pruritus. And as I mentioned, the possibility, since it could be a type 1 reaction, anaphylaxis. So when a patient complains of new drug and symptoms, one always needs to check the history carefully. In the US, if you watch any TV, you'll see all these drugs available, and the long lists of the pharmaceutical company has to list for the patient, so that their doctor, it sort of makes it look like the doctor never takes a history, which I would hope I never have a resident that doesn't take a good history. So the general types, probably this is the most common one, and then urticarial, and of course as dermatologists, we'll see morbilliform and photoallergic reactions. The other thing has happened, the severe reactions, it's convenient to kind of put these together. Stevens-Johnson, TEN, DRESS, you heard about earlier, and IGA Bullous diseases. So these are very significant reactions, often life-threatening. And what's interesting is we used to always consider that the Stevens-Johnson syndrome, probably at least a third of them were related to infection. And one of those was mycoplasma, and another is epilepsy therapy. But there has been some other studies that say maybe mycoplasma causes, it's not a drug reaction, but it causes a syndrome like Stevens-Johnson. DRESS has been mentioned. There are probably a lot of things if you're a lumper that fit in with this. And it stands for drug reaction with eosinophilia and systemic symptoms. It can be catastrophic for a patient. We've had the Dapsone syndrome and a lot of other things, and these usually are ending up in the intensive care unit. But you'll get facial changes first, maybe swelling of the hands, nodes, morbilliform reaction, and it can be severe and life-threatening. What we often don't think of when we're dealing with a skin problem is what is going on inside, and that's getting to be more and more in the literature. And one of the things was just last month in the JAD, looking at liver abnormalities. In the last year, another one was looking at someone who has a severe DRESS reaction, goes home, and inadvertently gets re-exposed. The studies that have been done show that they'll get the reaction, but it's usually milder, so that's comforting. We learned about venurafenib earlier, and it's mostly treated for melanoma and pediatric central nervous system tumors. And so this is the type of melanoma and in pediatrics. And what we're seeing now with this is a paniculitis. And just more recently, we're understanding that it has to do with the drug, because so many of these pediatric patients were worked up for infectious paniculitis and nothing found, no response to treatment. So then we came around to the conclusion that this is related to the medication. And I think we're going to see more of this with the Biologicals, because as Dr. Bowe's slides show you, some of them are extremely specific, but some of them are much broader and they have a lot of effects, and we're just beginning to document how they present in the patient. But with this, they usually responded to non-steroidals, sometimes systemic steroids. And another one is mostly with hydralazine for hypertension. And these are patients who have the PANCA or MPO antibodies. And patients with these, if they're given propylthiouracil, hydralazine, minocycline, and some of the TNF-alpha inhibitors, and interestingly, there's levamisole, something I did a lot of work on early in my career as an immunomodulator. It's in cocaine to keep it in its pristine shape. So people with the drug habit will present with vasculitis. So this is a direct interaction with those antibodies and the blood vessels. So we have a lot of very unusual reactions that you keep up with, as I'll tell you shortly. First thing you do when you see a patient is you look at the chart and you look for anesthesia, especially the aromatic anesthesia medicines like phenobarb, dilantin, carbamazepine. Allopurinol gives us a lot of business as dermatologists. Sulfa and dapsone, although my first paper on dapsone, I quoted there were 12 million people taking dapsone around the world every day. That was 1970, because it was a standard treatment for malaria and leprosy. And other ones, minocycline again. It seems like if you use minocycline, you've been lucky. We'll go to meetings and somebody is presented with a minocycline complication and people shake their head and said that drug should be outlawed. So you get, I guess it's luck of the draw. But minocycline can do concern, vancomycin, amoxicillin, and Cipro. So those are the ones I look for when I scan the chart. We talked about mycoplasma. Recently there was a paper looking this over because it has been documented to cause a mucositis and a rash, and it's now considered in many it's the primary reaction of the mycoplasma. It's not, you don't get that mixed in with the adverse ones. Sometimes SJS and TEN, and the article this year raises the question, is this cutaneous reaction primary or secondary? And more importantly, does it have anything to do with the medications the patient is on? We've emphasized the importance of urticarial, angioedema reactions and ACE inhibitors, antibiotics, anticonvulsants, biologicals. So here again, you check the chart. Dermographism can be a totally benign situation without sequelae. This is my Michigan days, just about the time we're playing Ohio State to see who goes to the Rose Bowl. So people like this is not considered an allergic reaction. Itching, widespread itching like this is usually one of the manifestations because it's much more extensive than you see with dermographism. But it's very important to check the patient for physical urticarias in the evaluation of the itchy patient, because cold urticaria, solar urticaria, there's this whole list that you need to think of when you're seeing a patient. And then with vasculitis, we'll see swelling and deep and tender symptoms. The differential for morbilliform reactions, fairly long, and of course right at the top is drugs. But you have to be aware of the various viral exanthems and the various herpes virus types, parvovirus, staph and strep and other bacteria, and of course New Orleans and our School of Tropical Medicine, we have a big focus on tropical diseases and parasitic diseases. And here's a good example. And of course, it's become very important to be knowledgeable about this, as we've seen this year in California with the measles epidemic, because we've had an increasing number of families determining not to have vaccination. So, in fact, California is at the crossroads right now that kids cannot go to school if they don't have the vaccination. So these are some other reactions. Mechanobullous, if you have blistering Stevens-Johnson syndrome, 5% mortality, TEN, 10% mortality, and then you have the other porphyria, pseudoporphyria, and the pemphigus-like. And here's an example. And also in that category is the so-called linear IGA Bullous disease, mostly in children. It can be related to a drug or spontaneous. We used to see a lot of them at Charity Hospital. We don't anymore, but this is one of those kids. Fairly characteristic distribution. And this was totally unrelated to any drug. But do you see much of that anymore, Aaron? You know, I think in the late 80s, several times a year, we'd have a child in Charity Hospital that I haven't seen one, and of course, I've not been at Charity for a while, but somehow this disease has gone away or ameliorated. And this is the bullous reaction. It used to be very typical patient with herpes, and they would get this acral bullous disease. Just looking at common reactions, EM and bullous ones, this doesn't quite show real good, but allopurinol anticonvulsants are one. Two is ataractics, and you see mostly bullous ones. And 3 is sulfa. So you can kind of work out a little scheme as to what to expect. Photoreactions, cortisone or amiodarone is kind of an interesting one. It's phototoxic. A lot of the ataractics may be both allergic and toxic. Fluoroquinolones, phototoxic. Sulfa drugs, of course, we see those, and other antibiotics. Pigmentary, that has a big gender thing. You almost never see it in male patients, but with females with hormone replacement therapy or the older high-dose OCPs can cause this. Distribution, you showed it there and you see it here. A young woman, this is a very old slide, my days in Ann Arbor, and she came in sitting out in her backyard in June in her swimming suit. Erythematous ones, this is a morbilliform erythematous one, and again, it's my impression we see this more in females, and a close-up, a morbilliform. And most of these resolve with scaling and things like this. So, therapy. Obviously, you look through your list, you tell the attending physician what to withdraw, and figure out the mechanism, to allow you an intelligent approach to treatment. Acetylator profile I mentioned earlier, it's getting to be more interesting because acetylation is a major detoxification route. So fast acetylators, mostly in Eskimos and Asians, African Americans and Caucasians, it's about half and half, so you can't rely on that. But if you have other exotic origins for your patients, it's something to think about because at a slow accelerator, you maintain high levels of the drug. So if the patient is a fast acetylator, they will probably clear up much more quickly. So that will help you a little bit in deciding what to do. And the pharmacotherapy, as you see here, just about everything we have, including, I'm a big user of dapsone as a steroid-sparing agent. It can have very severe reactions, but as I mentioned, it's used widely around the world, less so now because, like with leprosy, the bacterium started evolving resistance, but it's still used. If you're here and get a chance, this is Oak Alley. You go up the Mississippi River, there are some tours, you can do that, and you'll see these beautiful plantations that were along the Mississippi River, and it's worth your time if you have the time. So Jerry Litt has had his book out, and it's continually updated. How many of you are familiar with Dr. Litt's book? So I don't know its distribution worldwide, but it's gotten to be very important in the U.S. And cheat sheet, and if you see a lot of these patients, then you'll go through a protocol to help. I'd like to invite you, November, the IACD is in Rio, and hope to see you there. And thanks much for your attention. And we're right on time, so time for lunch. Any questions? Yes.
sorry. So welcome everybody to the afternoon session. I'm Rob Genscher from Albert Einstein. Hector, you met yesterday from Mexico, who will be chairing the sessions for you today. And our first speaker, Aziz Gahari, is going to present some very exciting data on new treatments for alopecia areata.
All right. Good afternoon, everybody. And for those who have not been in Vancouver, British Columbia, Canada, so this is the city of Vancouver. And as you can see, it's kind of peninsula, and 3 areas of it is water. And this is Stanley Park, and this is North Shore. We have mountain with the snow, and we can do skiing at the same time. We can come and do swimming. So that's the most livable city in the world, according to some basically information that published. So this is our building called the International Collaboration and Repair Discovery. So we're in 4th floor, and the second floor is offices and doctors and X-ray, and here 4th and 5th floor are the research. All right, so what I would like to do today is to convince you that the treatment that we have hopefully is going to give hope to patients who have some problem with the autoimmune disease, mainly the alopecia. And I'm sure that as a dermatologist, all of you are familiar with this alopecia areata, that this is an autoimmune disease. And so you can see that I've taken this one from this site, a skin site, and WebMed. So, so this is taken from the National Alopecia Areata Foundation. Usually they have a magazine that comes every month or so, that they basically have all the news about the alopecia universalis, alopecia areata. Bald is beautiful. And this is a twin that one of them has alopecia, one of them doesn't. So if you're interested in basically alopecia news, this is the very good, magazine to read, and you have all the news and all information research that is ongoing in this area. Okay, so now we go back to our work, and this is a mouse called the C3H mice. When is born, is healthy, happy, and very active, and unfortunately with time, so loses hair, as you can see here. You can see it here as well. So this is a patchy alopecia, and so you can, if you leave it longer, that's become like this. So again, very irregular, patchy area in different places. So you can induce this one by injecting lymph node cells or cells isolated from this one to another mouse. You can generate this one or induce it as well. But as time goes by, you can see that this become more toward the alopecia universalis. Again, you can see it here. So this is a very interesting pattern to see, very similar to human. So you can see some area we have patchy hair and none, basically alopecia areata in this area as well. If you wait longer, you can see this one, alopecia universalis. Basically, all the hairs is gone, and clearly this is very similar to alopecia universalis. You can see in human. So what happened is that, according to literature, so we have dendritic cells or Langerhans cells that reside in the epidermis, and when exposed to antigen, bacteria, or some other things, so that's become detached by through the inflammatory cytokines and loses the attachment, so gradually moved and become mature antigen-presenting cells and go to lymph node And in lymph node, we have naive T cells and exposed to basically naive T cells and activate these T cells. And where we have these antigen-presenting cells, you can see all of those cells are located in the epidermis. We have some antigen-presenting cells in dermis as well. And antigen-presenting cells actually function as a scanner. So therefore, it's going to scan any unknown molecule and then get the picture or get the molecules and introduce it to to T cells. So where is this lymph node? As you can see, we have lymph node everywhere, basically lymph vessels. And this is the section of lymph node. We have the B cells here. We have all these green cells are actually antigen-presenting cells, or red cells are in between. They are naive T cells. So therefore, naive T cells are sitting there waiting for the antigen-presenting cells to get there and activate them and then introduce the antigen and then activate them. And when become activated, actually, they go to the site of the problem. So under normal condition, we have the immunoprivilege at the hair area. And you can see that we have major histocompatible class 1 and not type 2 here. So type 2 is a pink one here. So when we have this one here, so immune cells actually migrate there, and most of the cells that are in this area and attack the hair follicles are CD8 and CD4. So therefore, if this one is gone here, and we lose the immunoprivilegency of the hair follicles. So you know that there are so many different treatment for alopecia areata, and so how our model or our strategy is different from any other type of treatment in the market. So I would like to introduce to you to a gene called IGA, or indolemin 2,3 deoxygenase. So what happened is that for many, many years, immunologists actually try to answer the questions that when we have male and female, and the children basically have completely different set of genes. Even though they have completely different set of genes, but still the fetus, which is kind of semi-allogenic, is not going to be rejected during pregnancy. So that was a huge question until 1999, that they identify a gene called IDO, indolemin 2,3 deoxygenase. This IDO expressed by the syncytial trophoblast, and so in the placenta. So therefore, by increasing the level of this one during pregnancy, and that's become protect the fetus from rejection. How does it do it? This way, we know that the tryptophan is essential amino acid. So therefore, immune cells need tryptophan to synthesize, and without tryptophan, the protein machinery cannot work. So therefore, without that, they cannot produce enough of the proteins that they need. So tryptophan with IDO break down tryptophan in response to actually interferon gamma, which is increased during pregnancy. And as a result, we have the major product called kynurenine. And this kynurenine can basically convert it to chynuric acid. Depends on type of cells that we have. If we have different enzyme, and then go all the way to different pathways and different molecules. And this pathway is very, very active in brain. And so let's see what happened. So here is antigen-presenting pseudodendritic cells. So in response to T regulatory cells, we have the interleukin, and interleukin stimulate IDO. But at the same time, as I mentioned, interferon gamma also induce IDO. When IDO become activated in cytoplasm of the cells, so as a result of that, the tryptophan level goes down, and then the kynurenine goes up. So by two different mechanisms is controlling the immune cells. When tryptophan goes down, T cells proliferation inhibited because of the lack of tryptophan. And at the same time, cornering goes up, this is toxic for the cells, and cells go to apoptosis and die by two different mechanisms. So if this one the case, we said, okay, maybe what we can do, we can have a gene, IDO basically vector. This is adenovirus, and this is IDO gene that we put it in with the GFP. And then we put this one into fibroblasts here, so or keratinocytes. So therefore, when this gene is expressed, we are hoping that the environment becomes very similar to placenta environment. So what happened is that when this becomes similar to environment, we have T-cell inhibition, we have the apoptosis happening. So therefore, when we inject this one into alopecia area, we might be able to block the T-cell proliferation and also apoptosis of T-cells. So before doing in vivo study, we did in vitro. So here we have mimicked the situation. We have fibroblasts that expressing IDO. This is immune cells. In this immune cells being PBMC and Jurkat cells, which is CD4 cells, and THP1 cells, which are basically macrophages. You can see that if you expose this one with IDO cells, this is mock infected. That means the vector or fibroblast without the IDO. So nothing happened. But when you have IDO, the number of PBMC that die 18% in 2 days, CD4 cells 82% die in 2 days, and macrophages 35% die in 2 days. So therefore, there is a clear indication that the immune cells, especially CD8, CD4, and macrophages cannot survive in this environment. And then the question was that when you have the IDO, so what happened to skin cells themselves? So we tested this one, and you can see this is fibrous. Again, we have mock cells. We have other IDO cells. And if you look at day 5, day 10, day 15, still the number are very similar. So therefore, the IDO that deplete the tryptophan or increases carnitine doesn't influence the T cells or the fibroblast one. So why is that? And if you look at literature, is as I mentioned, IDO break down tryptophan to carnitine and causes to apoptosis. But at the same time, in the tryptophan can increase the uncharged tRNA and activates a pathway called GCN2 pathway and lead to cell cycle arrest. And and then if you want to look at this pathway, so you have to go here, and the CHOP is the end product. So we can look at the CHOP to see whether this is all this abbreviation here. So CHOP, if you look at it, and you can clearly see that it's not coming. Where is it? Okay. If you do an experiment and then you have the interferon gamma to induce IDO, and you have CD4 cells and CD8 cells, CHOP expression goes up. That means the estrous pathways become activated, and the caspase-3, which is a sign of apoptosis, also activated. However, if you have 1-methyltryptophan, which is inhibitor, you can block this one. But under the same, basically in experimental condition, neither fibroblast nor carnitine, nor keratinocyte actually express any of those pathways. So therefore, the difference between immune cells and fibroblasts is that one of them has a stress pathway, another one doesn't have a stress pathway. That's why the immune cells are sensitive to low tryptophan and high carnitine, but the fibroblasts and keratinocytes are not. So we go back to actual experiment here. So what we did, we isolated fibroblasts from mouse, and then genetically modified to express IDO. And then we injected 1 million fibroblasts expressing IDO in this patchy area. and then we look at the alopecia areata treatment area. So the way that we treat it, as you can see that this is untreated alopecia areata, but this is the cell that we label it first and then inject it. So all the fibroblasts that are expressing IDO is located in this area here. And then, so okay, so what happened is that according to our findings, due to time, I don't have time to show all those things. It seems that when you're injecting fibroblasts that are expressing IDO, is going to migrate all the way to lymph node as well as the antigen-presenting cells. And fibroblasts has a two co-inhibitory factor called PD-L1 and PD-L2, so therefore activate the activity of the antigen-presenting cells. As a result, we can see a lower number of activated T cells. So that's the basically diagram that's showing here. For activation of T cells, this is antigen presenting these T cells, we need co-stimulatory factors. And if you have more of co-inhibitory factors, this is not going to be activated, the PD-L1, PD-L2, and is going to block the activation of T cells. So therefore, fibroblasts that has the PD-L1, PD-L2 may interact this one and compete with these cells, so therefore block the activation of antigen-presenting cells. So let's see what happened here is that, so this is the patch area that we have the mark here, where injected IDO-expressing cells. This is day 0 and this is day 60. Clearly you can see that in patch area we have so many, the hair came back. Not only in this area we can see some hair is coming back from this area as well. So that clearly shows that the injection of the IDO fibroblast therapy block the activation of the infiltrated immune cells. This is another example. Again, we have this before treatment, and this is higher magnification. This is after treatment. Clearly, you can see hair came back again completely. This is the mark that we have here is black. Here is your mark. So is indication that our IDO cell therapy is working to bring it back. And then when we sacrifice these animals, what you see is that the alopecia areata treated compared to untreated one, spleen is very big, but at the same time, the lymph node isolated from this non-treated one is so big, and we have a graph for it, but compared to treated one. So that means the IDO expression, not only hair is going to come back, influences the spleen as well as the lymph node, so inflammation is going to go down. At the tissue level, so these brown cells, I don't know, you can see them from the back of the room. The brown cells are CD3 cells, and this is the H&E, this is the specific staining. When you have treated, all these brown cells are disappearing. So that means that not only hair is going to come back, and because of the basically infiltrated immune cells are not going to be there. So now block the activation. And then we did another set of experiment. Okay, here is alopecia universalis, where injected cells in this area, and in some, actually in all of them in two sites, one here and one here, is, I don't know, is maybe not clear from the back of the room. This is mouse number 1. This was September 5, 2014, September 19, October 7, and October 29. And you can see some sign of hair or growing from the back. So if you continue, this one is a clear indication that hair are growing back from this area and going back here as well. So this is mouse number 2. So we did the same thing, and but this actually hair is coming back much faster than the mouse number 1. So hair is coming back here. So after only one time injection, so we don't need to repeat this experiment or inject more. And after some time, you can see hair is completely came back specific that is area. This is mouse number 3. You can see that again, we have more hairs in the back here and here. And this is actually mouse number 4 and number 5. So it seems to be very reproducible procedure. So this is December 20. So hair came back completely here. So that shows that our procedure is working. But unfortunately, we have to sacrifice this animal because of you want to get the data out and see what's going on inside the lymph node, inside the skin as well. So we didn't keep it for a long time. But now we have another set of experiment that we are doing with different and see how long, what is the percentage of those animals that get alopecia and what the dose that we have to inject, because at this time we inject 1 million cells. We want to see whether we can inject less or more. So in our conclusion is that the good thing is that these are PHARVAs, and the PHARVA cell therapy is become very common, especially for different skin diseases. So we are hoping that the IDO cell therapy become a new strategy to overcome some of the dermal autoimmune diseases such as AA, maybe psoriasis as well. So I would like to acknowledge the support of the Canadian Institute of Health Research and WorkSafe BC, Spectre Energy, and Hospital Foundation, firefighters, and INCIRC, and also International Brotherhood of Electrical Workers for this work. So also I would like to acknowledge the member of my research group, especially Dr. Jalili and Dr. Kilani and some others, and Dr. Lee. But some of them are not really here, that this is a kind of old. And of course, collaborator of Dr. Kevin McAuley, who provided us with the model, is well appreciated. And this is Vancouver on a cloudy day. Thank you very much. Any question?
Much. All right, so hello and thank you for having me here today. As you said, my name is Zachary Cooper. I'm from MD Anderson Cancer Center. I work with Jen Wargo over there, who's a surgeon. And I'm talking about understanding response therapy and rationale for combination strategies in melanoma. So I'm going to change, I guess, the theme a little bit and be probably one of the first people talking about cancer in a little bit. So melanoma remains a major cause of morbidity and mortality worldwide. However, within the past decade, key genetic mutations have been identified in melanoma which result in increased oncogenic potential and have been identified as targets for therapy. This includes mutation BRAF, which is at the top up here, and that's found in 52% of melanomas, as shown by the recent TCGA data that was just published in Cell. So treatments targeting this mutation has been one of the biggest breakthroughs in melanoma therapy, and the first of these agents was FDA approved in 2011 based on a clear survival advantage over then standard of care chemotherapy. However, there are limitations with this treatment, with the majority of patients progressing on therapy within 6 months. So insight into resistance mechanisms has led to advances in therapy, including the use of combined BRAF and MEK inhibition, which was shown to improve progression-free survival in patients as seen on the bottom right. However, even with combination, the majority of patients progress within a year, and there's a critical need to identify pretreatment markers of response and resistance, as well as early on-treatment markers of resistance, which are potentially actionable. So through the analysis by our group and many others around the world, we have gained a lot of insight into resistance to BRAF inhibition, and multiple mechanisms of resistance have already been identified. There's also been tremendous success in melanoma treatment using immunotherapy and immune checkpoint blockade. I show data here for treatment with immune checkpoint inhibitors targeting CTLA-4 and PD-1 and PD-L1. And it's important to highlight that though not all patients respond to therapy, however, when they do respond, it tends to be durable. Note the x-axis on the top left graph where you see that extends to 120 months or 10 years out. So, however, there's still a significant proportion of patients who are not responding to therapy. And again, there's a critical need here to identify markers of response and resistance for this form of therapy. So there's now tremendous interesting combination of BRAF targeted therapies with immunotherapies. The basis for this is the fact that in addition to causing increased proliferation and invasion and metastasis, oncogenic BRAF may contribute to immune escape. And we have shown that blocking BRAF using targeted therapy may make tumors more immunogenic. Today I'm going to show our preclinical and clinical data supporting potential between BRAF targeted therapy and immunotherapy. So to gain insights into resistance therapy, we performed longitudinal analysis, tissue analysis in patients treated with targeted therapy and recently added immunotherapy. In this diagram, I show our schema regarding time points in which analysis for clinical specimen is done. When a patient is enrolled onto a trial of targeted therapy, they're also enrolled into a tissue acquisition and use protocol. So a pre-treatment biopsy is done before initiation of that trial. Then they get an early biopsy early on treatment, and then we restage as necessary. And then if they progress, we get another tissue biopsy. So then we will perform genomic analysis, immune profiling, as well as RNA sequencing to better understand all aspects of the tissue. So before I go into the patient samples, here's a slide of preclinical data demonstrating that treatment of melanoma cells with a BRAF inhibitor results in increased melanoma antigen expression. So in this slide, we show immunofluorescence for the melanoma antigen MART1. The slide on the left shows melanoma cells cultured in normal media, and then these cells demonstrate negligible MART1. However, after treatment with a MEK or a BRAF inhibitor, you get an increase in MART1. We saw similar findings for all melanoma antigens. So we extended these studies to patients. Here we identified potential immune mechanisms of response and resistance through immune profiling and biopsies. Tumors were biopsied pre-treatment and within 10 to 14 days of initiation of therapy. Tumors were stained for the melanoma antigen MART1 again and for CD8 T cells. So here we demonstrate an increase in melanoma antigen expression and an influx of CD8 T cells within 2 weeks of initiation of therapy. And this is likely contributing to the response therapy. However, concurrently, we also saw a dramatic increase in PD-L1 on treatment, suggesting a possible mechanism of resistance. So an obvious question that arises is that given the advance in targeted therapy and immunotherapy, can we combine these two treatments to enhance responses? So now I'll share some insight gained not only from patients, but also from a murine model. So with these tremendous advances in melanoma treatment, we are poised with therapeutic dilemmas with regard to timing and sequence of therapy. Should we begin with immunotherapy and then switch to a targeted therapy at progression? Or should we start with a targeted therapy and then switch to immunotherapy at progression? So, however, there's critical questions exist in that can we use both these two forms of therapy together at the same time to improve responses? So there's certainly a strong clinical rationale for combining these two therapies for melanoma. This is based on the fact that each of these treatment strategies has limitations given as a monotherapy. Takes, for example, BRAF targeted therapy, where the majority of patients respond. However, it's very short-lived. In contrast, immunotherapy, you have a low percent of patients responding. However, it's much more durable. So, and we're hoping that combination with both of these two strategies will increase the amount of, or create a high response, but also create a durable response. So we want to test the potential synergy of targeted therapy and immune checkpoint blockade, and did this in two manners. We first aimed to perform multiple tumor biopsies in patients being enrolled onto clinical trials combining these agents. One of these trials was combining BRAF inhibitor with checkpoint inhibitor against CTLA-4. Samples were obtained prior to treatment, early on BRAF inhibitor, a little bit later in treatment, about a month in, and then after the addition of CTLA-4, and then far along in the treatment. And we also studied this combination in a murine model of BRAF mutant melanoma, and chose to study the combination of BRAF inhibitor with blockade of anti-PD-1 or anti-PD-L1, given the favorable toxicity profile. So as I mentioned, we didn't accrue many patients for this trial. For serial biopsies, that was closed prematurely. I think Tony Rebus published a paper in New England Journal of Medicine on that trial. But nonetheless, we have some provocative anecdotal evidence of increased CD8 infiltrate in combined therapy. So in this patient, we found virtually no T cells before treatment, and then you saw an increase early on treatment, even though there are some melanocytes there. But that wasn't very surprising. We've already published that in previous data. What was surprising was that the T cell infiltrate was basically gone about a month on. However, after addition of anti-CTLA-4, it was restored, and it persisted for months after he was off both drugs. So we also looked at the CD8 to Treg ratio by flow cytometry in collaboration with Arlene Sharp over at Harvard Medical School, and these mirrored the findings of the IHC. So we also developed a murine model through a collaboration with Martin McMahon, Marcus Bosenberg, and David Fisher. And this model is based on the original BRAF P10 model in Dancourt et al., and I think it's Nature Genetics. And we backcrossed this onto a C57 Black 6 mouse, and then generated a cell line which demonstrated the same phenotype we saw in the human sample, showing an increased antigen expression with the treatment of BRAF inhibitor. So we used this model to test for synergy. Mice were treated with a control chow, BRAF inhibitor alone, PD-1 or PD-L1 alone, or BRAF inhibitor plus anti-PD-1 or PD-L1. In these studies, we found that addition of immune checkpoint blockade to a backbone of BRAF inhibitor therapy improves responses with enhanced survival and delayed tumor outgrowth. You can see this in the survival plot on the left, where you get some treatment effect with BRAF or PD-1, but when you combine the two, you get a much better survival. These mice also showed delay in tumor outgrowth, as shown on the right. So when you look at these tumors, there is a modest CD8 infiltrate in the setting of BRAF inhibitor monotherapy. However, when you add PD-1 blockade to the backbone of targeted therapy, there's a dramatic increase in CD8 T cell infiltrate in the tumors of mice. Importantly, these infiltrating T cells were also more active. So with this as background, I'd like to share how we've gained even more insight into the resistance therapy in melanoma, and we'll first describe how we further characterize immune infiltrates in patients with metastatic melanoma. So this work stemmed from elegant work by Lisa Cousins' group, which was published in PNAS, where they analyzed the leukocyte population in breast cancer that was either chemotherapy naive or chemotherapy treated. We basically took their protocol, which we digest tumor biopsies straight out of surgery or out of the clinic, and then we use a 35 antibody panel to do flow cytometry, focusing on T cells, Tregs, NK cells, T cells, B cells, TAMs, TAF, DCs, and PMNs, and use a Fortessa to look at all the different leukocyte populations. Here's the gating strategy, but that's in the PNAS paper, so I'm not going to go over it. So we began these efforts about a year ago. I've collected over 90 melanoma metastases from over 60 patients. In this talk, I'm just going to talk about 39 of them. But results from the analysis of these tumors is highly relevant, as patients were treated with either targeted therapy, namely BRAF inhibitors or BRAF inhibitors plus MEK inhibitors, or immune checkpoint blockade, either anti-PD-1 or anti-CTLA-4. And you can see that we collected treatment-naive patients, patients that are on therapy, and then at time of progression. This is not a longitudinal analysis. This is just collected at different time points. So based on this unique cohort of patients, we use this analysis to see if there's a difference in the leukocyte-infiltrated melanoma tumors when patients progress on targeted therapy versus when they're progressing on immune checkpoint blockade. So this was something that our group wanted to explore after observations by Keith Flaherty and Jen Wargo that the kinetics of tumor progression on targeted therapy and immune therapy may differ. So here we show spider plots with tumor burden on the per RESIST criteria on the left, with individuals compared to the baseline at various time points. The top is BRAF plus SMEC, on the bottom is anti-PD-1. Basically, the red lines are all patients that progressed on therapy. Patients who progressed immediately on therapy per RESIST were not included in these cohorts, first of all. So on the right is a graph demonstrating the slope of disease progression per RESIST relative to the pre-progression slopes for targeted therapy or immune checkpoint blockade. And you can clearly see the higher slope of progression for targeted therapy versus immune checkpoint blockade. So when we pulled the flow cytometry data from the patient cohort I previously mentioned, we see some interesting findings, namely that there are clear differences in leukocyte competition between the treatment-naive patients and those treated with either targeted therapy or immune checkpoint blockade. So for this talk, I'm just going to focus on the T cells. So when you look at patients on targeted therapy, we see some very interesting results, namely that the CD8 T cell infiltrate is increased early on treatment with the BRAF inhibitor. However, at progression, they go back down to around baseline. So this is actually reassuring to us as we've been studying the immune effects of BRAF inhibitor for several years. And we've showed this previously in clinical cancer research. And these are just representative images from that manuscript. But that was very reassuring to us and helped us validate our methods. However, when we look at immune checkpoint blockade cohort, we see very different results. Namely that the CD8 infiltrate is increased early on treatment, and actually it remains high at time of progression. So we also performed IHC on these tumors and saw very similar findings. In contrast to our CD8 data, we did not see any differences in CD4s in treatment-naive patients versus those on targeted therapy or immunotherapy, nor did we see a difference in the Tregs. However, when you look more closely at the graphs of the percent of CD8 positive cells where each patient metastases is represented, two different groups of patients progressing on immune checkpoint blockade can be seen here. And it's either patients on anti-PD-1 or patients on CTLA-4. So the red dots here represent the patients that are on anti-PD-1, and the black dots are those progressing on anti-CTLA-4. And you can clearly see that the patients on anti-PD-1 have a higher percent of CD8 positive cells as compared to those on anti-CTLA-4. However, we have also looked at the activation panels as well as immunomodulatory panels by flow and don't see any significant findings. We're still trying to understand the differences in these immune infiltrates in patients progressing on PD-1 versus IPI. However, now we're actually sorting out CD8s and CD4s by flow, and we're going to be running RNA sequencing on these to better understand the differences in the populations. So with that, I'll conclude. There you go. So in summary, we can easily characterize leukocyte components in melanoma metastases. Interestingly, our studies highlight differences in immunophenotypes at progression on targeted therapy versus immune checkpoint blockade. Anti-tumor immune responses should be considered when contemplating timing and sequencing of therapies. And finally, there's much more research that needs to be done. So with that, I'd like to acknowledge a lot of people, but I'll kind of keep it short. Mainly my boss and a postdoc in our lab, Alex Rubin. Our team and collaborators is Grant that's funded most of this, Linda Chin, Keith Flaherty, and Arlene Sharp, and many other people from MD Anderson. But most importantly, I'd like to thank all the patients because it takes a lot of effort for these patients to go through all this and actually do all these biopsies, all these clinical trials. So with that, I'll take any questions.
Thank you, Dr. Zakari. Any question for the Dr. Zakari?
am I? This one. All right. So thank you very much, and appreciate everybody coming after a nice lunch. And in spite of all the intriguing invitations to things to do in New Orleans, just remember it's the nightlife. So we'll enjoy the afternoon session first, of course. I'm from Albert Einstein College of Medicine and Children's Hospital Montefiore, New York. I'm a pediatric endocrinologist. In terms of what my interest is in calcitropic hormones, and there is a lot of crossover calcitropic hormones and actions in the skin. We heard about vitamin D effects yesterday, which I think are pretty well known at this point, but what I'd like to talk about more today is parathyroid hormone and parathyroid hormone-related peptide and its actions in the skin. This is all in the context of alopecia, and as Aziz introduced us to one form of alopecia, which is alopecia areata. Of course, there are many others, the most common form being the various forms of androgenic alopecia. That includes male pattern hair loss, and in females affected by polycystic ovarian syndrome. There are drug-induced, which is primarily chemotherapy-induced alopecia, certainly is highlighted as one of the major complications of chemotherapeutic regimens. And then other causes including scar tissue, psoriatic tissue, which does not have hair follicles, and endocrine disorders. I have to mention hypothyroidism, of course. It's a huge problem. So androgenic alopecia affects up to 2/3 of males past age 35, so none of us have to feel bad. Polycystic ovarian syndrome, of course, a very common syndrome for females, ranging in 4 to 12% of the population affected. Alopecia areata affects 2% of the population. And for those that are receiving chemotherapy, very common to have some form of alopecia, 65 to 85%. And this is a major issue for those individuals. They consider it to be a traumatic or the most traumatic aspect of the chemotherapy, and actually does lead to some folks declining chemotherapy, particularly with palliative regimens. Now, in terms of the current therapies, there are somewhat effective medications. Minoxidil, of course, was found pretty much serendipitously. It was an antihypertensive that was found to stimulate hair growth, so repackaged into a topical formulation for that purpose. Spironolactone is an androgen receptor blockade, which is used pretty significantly in polycystic ovarian syndrome. Finasteride or Propecia is the blocks conversion of testosterone to dihydrotestosterone for male pattern hair loss. Cooling caps have come into use for chemotherapy regimens where basically you reduce blood flow to the scalp and reduce the exposure to the chemotherapeutic agent. And of course, there's always hair transplants. There's a problem here in the United States. The FDA does not consider hair loss to be a disease. They consider it to be cosmetic. So when they're considering the risk benefits associated with the efficacy versus the side effects of a medication, hair loss treatments have no benefit, therefore can have no side effects. Unfortunately, this leads to lack of enthusiasm for pharmaceutical development and leads to pretty significant issues with off-label use. Corticosteroids, cyclosporin, some relatively dangerous immunosuppressive treatments have been used. I have to mention in this context, I had a patient that's deceased now from fulminant lung disease who was on these agents for alopecia areata. Just to remind everybody quickly of the hair cycle, we have the anagen phase is the critical one for hair growth. That's where the hair follicles are actually growing and increasing in size, and that's where the hair follicle penetrates into the subcutaneous fat layer. The transitions to catagen and then to the telogen in the resting phase, of course, complete the cycle. The initiators for the telogen to anagen transition are known. Beta-catenin, left one, and I should mention the unoccupied vitamin D receptor, actually thought to form a complex, and that complex is a stimulus to initiate the hair cycle. Now, parathyroid hormone-related peptide is a bit of a mouthful. It's obviously related structurally to parathyroid hormone, which is how it gets its name. This is a paracrine factor, though, and it's made in various tissues throughout the body, has different effects. In the bone, its primary effect is as a growth plate regulator. In the skin, it acts at receptors in the keratinocytes and actually functions as a hair cycle regulator. In terms of its mechanism of action, as I mentioned, the homology to parathyroid hormone, well, they do act through a common receptor called, of course, the PTH-PTHRP receptor. This is a G protein coupled receptor. It links through the GS-alpha cyclic AMP mechanism. But downstream from this are activations of the Wnt pathway and included increased levels of beta-catenin, at least in bone. The work in terms of PTHRP effects in the skin goes back 20 years now, 1994. My colleague and others, landmark paper from the PNAS. This is the primary effect, PTHRP inhibiting keratinocyte proliferation. And interestingly, back then they noticed that PTHRP antagonists could induce hair growth. Now, this is in a model called the SKH1 hairless mouse, which I don't believe at that point they knew what the defect was. We know now that there's actually it's a mutation in a gene that's called hairless that regulates another protein called WISE, which is a Wnt inhibitor. It's actually homologous to the sclerostin that's being pursued now for osteoporosis treatments. This is a very interesting model, once again, very early studies, where the FGF5 knockout mouse, for those who aren't familiar, this is a mouse that gets locked in anagen phase. So normally mice, hair follicles don't spend much time in the anagen phase. They're mostly in telogen, and that's why their fur doesn't grow to unlimited length. But in these mice, they become quite puffy. And it's because the hair follicles don't make this transition. So this is a cross between these FGF5 knockout mice and a PTHRP overexpressing mice with a K14 promoter for the skin. And you can see the effects on the hair. It actually restores the normal coat by allowing the hair follicles to transition out of anagen. And these are studies with PTHRP blockade and chemotherapy osteoporosis. So this is a model where the animals are waxed, depilated, and then they're given the chemotherapeutic at the time of maximum sensitivity when the hair follicles are in anagen. And these are animals that did not receive chemotherapy. These animals received the chemotherapy. You can see a cranial to caudal hair regrowth pattern. And these animals received a PTH antagonist, multiple doses, and you can see improvements in the hair growth. So this leads to a model of PTHRP in the hair cycle where it's actually inhibiting the transition from telogen to anagen and promoting anagen to catagen. And I've shown basically where the mouse models that we've talked about so far, how they enter in. And what this ultimately leads to is a hypothesis that PTHRP blockade would promote hair growth, particularly in chemotherapy alopecia. So this led into clinical trials and with a topical formulation. And unfortunately, these clinical trials are very disappointing. And you won't, for those familiar with the literature, you won't find this in the literature, but where you will find this is in the company reports from IGA Pharmaceuticals that was running the trials. It was discontinued in phase 2 because of lack of efficacy. In terms of why something like this might fail, a fairly obvious reason jumps out at us, which is when you're trying to antagonize something and you're giving a very short half-life peptide, even if it's topically administered, how do you maintain the levels long enough to maintain the blockade? Another issue, actually going back to the original report by Peters, these are the antagonist-treated animals, but below here, these are the animals that were treated with the agonist, PTH1 to 34. And animal C here in the first panel, E here in the last panel, are basically the corresponding treatments, antagonist, agonist. And there certainly is a clue that the agonist may have had as much or even better effect on the ultimate regrowth of hair at 30 days. So to pursue this further, we actually used a collagen targeting technique, and this was in collaboration with Drs. Matsushita and Sakon, who developed this collagen binding domain as a drug target. And it binds in a fairly nonspecific fashion to triple helical collagen, including, of course, type 1 collagen in the skin. And we made a fusion protein, actually made several fusion proteins of this with parathyroid hormone agonists and antagonists. The constructs are shown here. The distribution of this peptide, based on an S35 labeled compound, it does indeed go to the skin. It was also actually designed to go to the bone, and it does go there as well with subcutaneous or intraperitoneal administration. Looking at this in the model of chemotherapy alopecia, basically this is the same study as what Peters and all did. The only difference being, instead of using multiple doses of the compound, because these are retained in the skin for a long period of time, we just used a single dose. And it was given on day 7, 2 days before the chemotherapeutics were. The results that we saw, though, were actually quite different. The normal controls, the ones that did not receive chemotherapy, did have anagen transitions because of the waxing injury, but they ultimately regrew all their hair within the 36-day time period. Those that got chemotherapy had very limited regrowth of hair. Those that got the antagonists really didn't look much better than those that got just the chemotherapy alone. And when one looks at the histology, it actually looks, if anything, a little bit more detrimental. There's a little bit more of the dystrophic changes that are characteristic of the chemotherapy. And then those that got the agonists were actually the ones that responded with more of an androgen reaction and with the increased hair growth. On a separate study, we looked at dose response. Now, noting the cranial to caudal progression, we decided to inject caudally to see if we could induce the hair growth at an earlier time point in an area where it otherwise wouldn't happen. So that's why we're focused on this lower portion of the animal here. And this was actually taken at day 24, and we can see that there's a dose-dependent speeding of the regrowth of hair and a reversal of the normal cranial caudal progression. We did also look in the autoimmune mediated hair loss model using the same C3H-HEJ mouse that you heard about earlier. A variety of dosing regimens, agonists and antagonists. And as our primary endpoint, basically used a quantification of the hair growth by a grayscale analysis to look at the proportion of animals that had reversal of their hair loss. And we actually got different results depending upon where we looked in the animal. So overall, the agonists were quite effective at reducing the hair loss on both the dorsal and ventral surfaces, but the antagonists that were ineffective on the dorsal surface actually had much more beneficial effect on the anterior surface. Some of this may have to do with the accessibility of the hair to grooming. That's why we looked specifically at the thigh hair loss, and presumably any positive effects of the antagonist would have been in the prevention of the anagen to catagen transition. This is representative of what can happen with these animals. On the top, this is a vehicle-treated animal that did not have the immune response. Only about 80% respond. So when that happens, you have a normal-looking animal, normal-looking skin histology, you have no infiltration of CD8 cells in the hair follicles, and a fairly minimal production of beta-catenin. In the vehicle-treated animals that did have an immune reaction, we actually have it's very hard to even see the hair follicles because they're surrounded by these immune cell infiltrates. And they do stain as CD8 positive, which is typical for this model. And very little reaction in terms of beta-catenin production to induce antigen response to regenerate the hair. Animals that are treated with the agonist compound, the PTH1-33 with the collagen binding domain, apologize for the cross-section, but I wanted to emphasize just the sheer number of hair follicles, all these circles in the subcutaneous fat. Once again, we see the same type of immune response, but we're also seeing increased beta-catenin production, presumably as a direct result of the drug treatment. We did count them. It took a while. It's fair to say that basically all treatment groups had increased number of hair follicles compared to the vehicle. And that includes the antagonist, and once again, probably emphasizing these having an opposite mechanism preventing existing antigen hair follicles from transitioning out of that phase. So what I offer to you now is a revised model of PTHRP and its effects in the skin. I didn't show you data on this, but there's actually a very good data from the group in Yale about the overexpression of PTHRP inducing nipple epithelium lineage, which originally was misinterpreted as inhibiting hair follicle and folliculogenesis, but it's actually a positive effect on just creating a different skin type. Within the hair cycle, though, it appears that PTHRP has positive effects not just on transition out of the anagen phase, but also on transition into the anagen phase, and increases the speed of the hair cycle. And in this context, it starts to become a little bit clear how we're getting the effects that we've seen before in the 3 different types of mouse models. In the hairless mouse, if you block PTHRP, you don't lose the telogen to anagen transition because you've already got that blocked by the nature of the defect that you have. So you will see increased hair growth with this blockade. But in the chemotherapy and the alopecia areata, the predominant effects are going to be in making more hair follicles enter anagen and ultimately replacing the damaged follicles. So in conclusion, PTHRP agonists act through the PTHRP receptor in keratinocytes, ultimately activating downstream mechanisms of beta-catenin and stimulating the hair cycle. This does represent a new target for drug development for several forms of alopecia, including alopecia areata, chemotherapy alopecia, and we suspect, unfortunately we lack good animal models, but for androgenic alopecia where the defect is thought to be PCOS, is thought to be related to beta-catenin loss. Acknowledgements, as I mentioned, Dr. Sakon and Matsushita developed the collagen binding domain targeting that we use for these compounds. Drs. Tulasi Ponapakam and Rajita Katakaneni primarily responsible for the data with these new compounds that I've shown you. Funding sources for the experiments include the National Alopecia Areata Foundation, who you've been introduced to, and the Albert Einstein Institute of Clinical and Translational Research, the National Science Foundation. There is a commercialization effort on these compounds that was intended primarily for bone, but actually is now starting to head into the skin arena as well, too. So we're hoping that some of these types of technologies will find their way ultimately into the clinic through this route. Thank you very much.
Thank you, Dr. Robert. Any question for the Dr. Robert? No?
I'm sorry, yes?
In vivo. Today, the study is in vitro and respond different questions about the fungi. Okay, no problem. Remember, yesterday talk in the web only studies about the laser. The laser is ND-JAK. ND-JAK long pulse is laser specific to the vascular problems in dermatology, in hemangiomas, on vein lanes, on face veins. The difference in the industry, the laser used in the onychomycosis, this laser long pulse, because the most common fungi in the onychomycosis is terrubrum. Terrubrum produce red color. And this indication used for this disease. Who is the problem? The problem is the long pulse is like a whiplash. It's a very strong shoot, and this shoot into the skin, deep to the veins or to the blood. When you shoot in the nail, the painful is like a whiplash. If you shoot overlap in the same place, you destroy. This is the problem. The different machines to the long pulse, only 1 hertz. 1 hertz is 1 shoot. It's different to the quick switch. Quick switch is superficially and is very less in the skin and most specific. Check this study. It's most specific in different colors and different disease. The most common is in removed tattoo. The removed tattoo is different colors and different points for the quick switch. What's the difference? The quick switch is possible shoot in this overlap in the same place. The hertz is 1 at 210. It's possible like a gun machine in the same place and don't destroy. It's like a shoot in the target. Check the results. The problem this study is pink above the color to the terrubrum. This keep it to Greek think the red color is the only the cause to destroy to the fungi, but no, it's true because when check the cultures, look at because no is only color or only the hat. This is a study for my team, publication last year in the journal Cosmetic Dermatology. I use quick switch, but only use one tip, and 1 session, 3 pass, no pain, no effect adverse. And this is the form in horizontal, vertical, horizontal, 3 parts. This is the 3 hertz in the same place. It's possible with the long pulse, no, it's possible. These are the results. And EPL. Who is the similar quick switch and EPL? EPL is but similar to quick switch because it's possible shoot in the same place, in no pain, but the mechanical and the light produce, look at penetration in the half line. This is the similarity to quick switch. Okay, this studies EPL and onychomycosis, good results. This is our study. This is a machine, EPL and quick switch. Okay, look at first terrubrum, EPL, shoot. Look at reinoculate and clean. 14 sessions for EPL in vitro, terrubrum. Look at the terrubrum distortionate. Canis, look at it's EPL, reinoculate, and clear. 27 sessions. Change, look at, very important. Look at canis, pre, and post. Remember, yesterday I said destroy the fungi, not destroy. Transformation or transmutation. If you, in física cuántica, the name is transmutar. Transmutar is change. Remember, the energy, don't destroy. Translate, transmutation. This is transmutation the fungi. Okay, tonsurans, reinoculate, clear, 6 weeks. Mechanobullous, look at pre, post, change, not destroy, change the fungi. The same study with the quick switch. One session, no. Canis, distortion might not destroy. Mechanobullous, look at one session. Tonsurans, one session, laser. Microscopy, don't destroy, only transformation or transformer. The deep fungi, this is, in my country, is very common, Fonseca pedrosoi, look at EPL, and look at in this picture, they have to or not have the difference. Look at and check. When reinoculate the tube, clear, irradiate, look at, and finish, clean. Quick switch, single session, look at. Sporotic Schenke is very common in my country, look at. Who irradiate and clean the tube. Look at, clean, and look at. Sporotic Schenke. And look at the microscope. Change. Remember, not destroy, change. This is one session for quick switch. Look at single session. Okay. Nocardia. Nocardia is very difficult. If you different treatments and look at, reinoculate, one session. Look, it's quick switch, microscope, Mycobacteria. Mycobacteria is very interesting. Look, the cultures, pre, post, EPL. Look at the bar, the same case. Look at, clean the bar. Finish. Conclusions. The EPL and quick switch is a good treatment for this disease. Maybe in the future, I think the two alternatives is open the door for the no cosmetic indication, because this is laser and this EPL is, the doctors say is only cosmetic. No, this is for medical indications in the future. Maybe in the future, the patient arrive to the office and to the, like a camera, and you shoot, and the patient walk to 1 month and clean. No pills, no medicine. It's very nice because it's cheap. In this moment, the EPL and the quick switch is very cheap. The new models is very expensive, but this equipment is the old. The old is a EPL traditional and quick switch traditional, no picosegundos. This is the conclusion. Remember, slide, heat, and impact power. In the long pulse, no is possible because the long pulse destroy, and quick switch no destroy. It's like a linear particle accelerator. It's very specific in the target, in the fungi, in the nucleus. This is the difference in the bacteria. If you talk about the EPL and acne, it's the same. You shoot in the face the patient with the acne. Is two possibilities. With the suction for a vascular zone and the concentration, the energy is better in the acne patients. If you don't have with the suction, the machine is the Isolas. If you have a traditional EPL, you should 3 times overlap in the same zone, and the bacteria to P. acnes clean. It's nice results and cheap. Thank you so much.
Excuse me, you transformed the fungi to the dukkha.
Mhm.
How can you be sure that you won't turn it back to Frankenstein fungi?
Oh, okay. Now, I work for the 2 biological and 2 mycological doctors, and this is new. In this moment, talk with the different corporation for their magazine Nature, and talk about this because it's new. The transformer and description for these new forms to fungi is, in the first I don't believe, but when you look this, say, I believe. Yes, the fungi is microorganisms perfect in the world, because the fungi you put here and live, and you put in the iron live. In all the place, the fungi is live, but transformation. This is for the future.
Yeah, it's stuck.
It gets a little slow sometimes, and we can lose the,
No, it's
it's
fine.
here. Yeah, it's just not going up to there.
Okay. This case, where's your mouse at? Where'd the mouse go? Come on, over to the mouse.
Shall I step down?
Okay, we need a,
Got zapped by the laser.
yeah, really. Something happened there. Come on, it's not a touch screen. Oh, I think I just saw something. Wow.
Shall I bring mine?
Well,
Shall I
this is
bring-
what it's gonna be right there. Let me see if I can get the mouse.
Okay.
We just start it over. The mouse isn't working. Touch screen got disabled. The mouse isn't working. Oh, he's got a mouse.
While we're waiting for the speaker, can I ask, he said that the procedure was very cheap for your
Yeah, the mouse doesn't work. That's the problem.
Shall I bring my laptop and just connect it or wait for him?
Do you have yours? Yeah,
I have mine.
if you know how to do it, yeah. Yeah. Mm-hmm.
Different factories, the laser, no? Alma laser fabrication in this moment in China.
Yep. The mouse isn't working.
You go to China,
Touchpad.
China,
Hit the dust.
the machine in USA maybe $45,000. In China, 300. Very cheap. It's the same machine, the same conditions, very cheap. You report to the office, and you, in my office, I say, in the first car washing, oligoscopy, and treatment in the same time, $3,000. Which passes pay.
Got a tail on,
That's
but
the only problem.
it'll work.
Yeah. The touchpad just
Voila.
hit the dust.
There you go.
So I have to just
Move forward. Just your
press here, it will be fine. Okay, good afternoon. Today I'll be presenting our study titled Evaluation of Serum Level of B Lymphocytes Activating Factor of the Tumor Necrosis Family, or to cut it short, BAF, and peripheral blood CD19 positive beta lymphocytes in patients with generalized vitiligo. As we all know, vitiligo is an acquired, progressive, multifactorial depigmenting disorder occurring worldwide with an estimated overall prevalence of less than 0.5%. It's characterized by loss of functional epidermal melanocytes. Three main hypotheses have been postulated to explain the process of vitiligo, which are autoimmune, autocytotoxic, and metabolic and neural dysfunction, of which today we will be discussing the autoimmune hypothesis, which is commonly associated with generalized or focal non-dermatomal vitiligo. It's believed that generalized vitiligo is a part of a broader, genetically determined autoimmune and autoinflammatory diathesis, namely beta cell autoantibody production and autoreactive T cell cytotoxicity. Just to have a brief about the role of beta lymphocytes in autoimmune diseases, it's well known now that the role of beta cells includes autoantibody active production, T cell activation, and regulation of T cell function and inflammation through cytokine production. The CD19 is a specific B cell marker that is expressed early during pre-B cell ontogeny and until terminal differentiation into early plasma cells. As was said before, follicular dendritic cell B cell interaction in germinal centers play a crucial role in full activation of B cells. FDC B cell interactions require two distinct but synergistic signals. The first one, derived through the beta cell antigen receptor, and is provided by the antigen itself and is responsible for the specificity of antibody secreted. And the second signal, in which CD19 is involved, is derived from the B-cell co-receptor complex, which consists of CD19, CD21, and CD81 bound to complement and is not antigen-specific. So, the beta-cell co-receptor complex is essential for the rapid trapping of complement-coated antigens by beta cells and thus is critical for early protective antibody responses to lethal pathogens. And the role of CD19 is thought to functionally be a linker between CD21 in beta lymphocyte complex receptor following co-recognition of complement 3D coated antigens and is a key player in the activation of beta lymphocytes. What about the BAF, which is our marker today? The beta lymphocyte activating factor of the tumor necrosis factor family, which is also known as beta lymphocyte stimulator, was identified in 1999 as a new ligand of the tumor necrosis factor cytokine family. It's mainly produced by myeloid lineage cell, constitutively synthesized by macrophages, monocytes, dendritic cells, and can be further induced by interferon gamma and interleukin 10. In addition, neutrophils stimulated with granulocyte colony stimulating factor and to a lesser extent, interferon gamma express BAF at very high levels. Not only this, it also appears to be expressed by T cells and dendritic cells for the purpose of beta cell co-stimulation and may therefore play an important role in the control of beta cell function. It appears to be a key factor for peripheral beta cell survival, maturation, and homeostasis. It also provides co-stimulatory signals to T cells, enhancing T cell proliferation and cytokine production. Like other members of the family, it can be present in the membrane-bound or soluble form, which we measured in our study. BAF is mostly cleaved from the cell surface and circulates as a soluble homotrimer. BAF binds 3 receptors. The main receptor, which is called the BAF receptor, it's predominant on circulating B cells, and it is the major mediator of BAF-dependent co-stimulatory responses in peripheral beta and T cells. The second receptor, TACI, or transmembrane activator and calcium modulator cyclophilin ligand interactor, seems to may in fact serve to downregulate the beta cell activity. So we see that different receptors have different effects on the beta cell activity. And the third one, the beta cell maturation antigen, can induce beta cell antigen presentation, but appears not to play a role in beta cell maturation, however, is involved in plasma cell survival. So it's clear that breakdown of the regulation of BAF expression resulting in excessive BAF production may lead to impaired beta cell tolerance, inappropriate survival of self-reactive beta cells, and autoantibody production, eventually leading to the development of autoimmune phenomena. And several studies have evaluated the level of BAF in different autoimmune diseases, such as systemic lupus erythematosus, rheumatoid arthritis, Sjögren's syndrome, among others, and it was found to be elevated. Not only this, but several BAF antagonists in the form of receptor fusion proteins or monoclonal antibodies have been developed, and results of animal studies and clinical trials in several autoimmune diseases have been so far encouraging. And this has led to the suggestion that BAF overproduction may be the underlying factor behind increased peripheral beta lymphocyte number, which could result in autoantibody production, leading to destruction of melanocytes and vitiligo patients. That's why in our study we aim to evaluate the serum levels of BAF and peripheral blood CD19 positive lymphocytes in patients with generalized vitiligo, and to explore the effect of treatment with narrowband ultraviolet B on their levels in an attempt to study the possible contribution to the pathogenesis of vitiligo. To achieve this, we included 30 patients presenting with generalized vitiligo and 30 age and sex-matched healthy control subjects. The exclusion criteria included patients with associated autoimmune diseases and patients already receiving treatment for vitiligo. Patients were subjected to detailed history taking, clinical examination, clinical assessment of disease activity using Vitiligo Disease Activity Score, the VIDA, and disease severity using Vitiligo Area Severity Index, VASI. And then blood samples were withdrawn to measure serum BAF levels and peripheral blood CD19 positive B lymphocytes. Following that, patients were treated with narrowband UVB and received 3 sessions per week for 3 months. At the end of 3 months, reassessment of disease severity was done using VASI score, and follow-up blood samples were collected from the patients. CD19 positive cells were analyzed using flow cytometer, and a BAF level was assessed using ELISA technique. The results came out as follows. There was a significant increased level of both the BAF and absolute lymphocytic count and CD19 positive cells in patients than in controls. However, this photo shows the distribution of CD19 positive lymphocyte in a patient and a control study showing the increased level in the patient. However, CD19 positive cells showed no significant correlation with the disease duration or the disease severity or the disease activity. And the same applied to BAF, which showed no correlation to the disease activity or severity, or also to the CD19 positive cell count. When we compared between patients before and after treatment regarding the VASI, the BAF, and the CD19 positive cells, only the VASI score was significantly different. However, both the BAF levels and the CD19 positive beta cells showed no significant difference before and after treatment. It's worth saying that only 20 patients completed the 3-month treatment period with narrowband UVB. The present study revealed peripheral blood CD19 positive B cells percent and absolute counts to be significantly higher in vitiligo, generalized vitiligo patients than in healthy control, which could be possibly attributed to the elevated BAF levels detected in our patients. Similar to serum BAF, peripheral CD19 positive B lymphocytes showed no relation to disease duration, activity, or severity. Treatment with narrowband UVB for 3 months did not seem to influence serum BAF or peripheral blood CD19 positive lymphocyte, in spite of the significant decrease in the VASI scores of the patients after treatment, indicating that those markers do not contribute to the factors behind the improvement of vitiligo after phototherapy. These findings suggest a possible role of BAF and beta lymphocytes in the pathogenesis of generalized vitiligo, pointing to the possibility of BAF being a potential therapeutic target for the disease. Detailed knowledge of the role that BAF plays in the pathogenesis of vitiligo may shed some light to possible outcome of targeting BAF for its treatment. To sum up, elevated serum BAF levels in generalized vitiligo may be responsible for the elevated peripheral blood CD19 positive lymphocytes detected in the disease. However, they are not the sole player. There must be other players that are responsible for the elevated CD19 positive lymphocytes, because there was no positive correlation or no significant correlation between the levels of BAF and CD19 positive B lymphocytes. The elevation in both serum BAF levels and CD19 positive B lymphocytes in vitiligo patients possibly provides further support to the autoimmune hypothesis of the disease and to the possible role played by beta lymphocytes in the pathogenesis of the disease. To the best of our knowledge, this is the first study to investigate serum BAF levels in vitiligo patients and its relation to disease activity and severity, and to investigate the influence of narrowband UVB treatment on the peripheral blood CD19 positive lymphocytes and serum BAF levels. And we recommend that further studies should be conducted in order to further evaluate the role of BAF. I have from my beautiful country, Egypt, and I wish that one day you will visit it, where you will find all types of tourism, wonderful beaches, some of the best beaches in the world, snorkeling, shopping. We have all kinds of monuments, pharaonic, and we have Greek and Roman. We have desert safari, mountain climbing, everything. Thank you very much.
It's yours?
No, I don't use this.
Okay. Dear Chairman, ladies and gentlemen, skin diseases and dermatology problems depend on many factors. One of the reasons is the damage of stratum corneum by the various substances. I'd like to present a part of study which I did with my team. The title is Consequences of Overcoming a Human Skin Barrier by Low Molecular, Cyclic and Linear Methyl Siloxanes silicones. What are the silicones? Polysiloxanes are commonly named silicones. They belong to the organosilicon chemical compounds. Polysiloxanes are composed of backbone with repeating silicon and oxygen atoms and various chemical groups, for example, methyl, ethyl, propyl, phenyl, vinyl. Depending on the size of molecule and the shape of skeleton, polysiloxanes can be linear, cyclic, branched, cross-linked first networks, and cross-linked second networks. In case of linear, these are volatile and non-volatile fluids, for example, dimethicone, cyclic, for example, cyclomethicone, branched, for example, silicone rubbers, soft skin adhesive from Dow Corning Company, cross-linked first networks present in resins, rubbers, and elastomers. Elastomers is a very important group because are used to treatment keloids or scars, for example, Zika care. An important group of silicones are linear polydimethyl siloxanes and cyclic polydimethyl siloxanes. They have methyl group and a various degree of polymerization. Therefore, linear polydimethyl siloxanes can be low molecular weight, medium, and high molecular weight. I'd like to note that according to the pharmacopoeia, only medium molecular weight can be used orally. In medicinal products, simethicone and dimethicone are used as anti-foaming drugs. The researchers argued that the medium molecular weight is safe for human being. Currently, I am interested in research with low molecular weight, both linear and cyclic. On the following slides, I am presenting a few examples. Why should we be interested in silicones? It's estimated that the sale on the global market for silicone will be until 2017 more than $19 billion, and report about silicones presents that the global production capacity has reached 400,000 tons per year. Why should we be interested in silicone yet? Due to the unique physicochemical properties, polysiloxanes are used in a wide variety of applications. A human being has a direct contact with silicones through medicinal products as an active pharmaceutical ingredient, dimethicone or simethicone, by food as a functional additive E900, cosmetics, by medical devices, for example, implants, prostheses, and tamponade, and by environment, by water and soil, which silicones are present as contamination. Why should we be interested in silicone yet? I would like to emphasize that a human being may have a direct contact of silicones with skin through dermal medicinal products, ointments against infection pathogens, gels for keloids, ointments for scars, emollients for atopic dermatitis, and products against lice. And by personal care products and cosmetics, hand and face cream, lotions and masks, protective creams against ultraviolet radiation, face gels, antiperspirant, deodorants, and shampoos. And by environment, because of significant amounts of contaminant silicones found in soil, water, and air. Contamination problem is described in the few reports of governments, for example, Canada, Sweden, and Denmark. Why should we be interested in silicone yet? It should be pointed out that the cosmetic industry dynamically develops in producing of personal care products and various cosmetics which contain silicones. According to the American Skin Deep database, more than 16% of the examined formulations contain polysiloxanes. By other sources, the polysiloxanes are presented in every second cosmetic. Why should we be interested in silicone yet? Generally, polysiloxanes are considered as non-toxic. However, there are reports about a toxicity of polysiloxanes. Both the linear and cyclic structure, and especially with low molecular weight. In literature, there is reported an impact on changing of proteins conformation, immune system, endocrine system, increase in liver enzymes, impact on the human skin, irritation and inflammations, cyst formations, and genotoxicity. Regarding the safety assessment of using low molecular weight polysiloxanes, it seems to be necessary to verify the possibility to overcome skin barrier by these substances. Therefore, we ask if silicones have the ability to overcome human skin barrier. In the study, the following three issues were considered: human skin structure and its impact on the overcoming skin barrier by xenobiotics, possible pathways of entry the skin, and physicochemical properties of the xenobiotics. Human skin barrier includes stratum corneum, epidermis, and dermis, but the most important layer which determines skin barrier is stratum corneum. Stratum corneum is composed of corneal site of and pentagonal shape, surrounded by bilayer lipid matrix. Due to the tight stratum corneum, its effective barrier against entering undesirable allergens, compounds, and microorganisms. We can consider 6 pathways by which chemicals diffuse into the skin: through the appendages, hair follicles, sebaceous gland, and endocrine sweat gland, by transcellular permeation and intercellular lipid pathway, and through corneal desmosomes. According to the theory, Lipinski of 5, through healthy skin can penetrate the low molecular compounds with molecular weight up to 500 Dalton, log pillows then 5, optimal from 1 to 3, hydrogen bond donor below 5, hydrogen bond acceptor below 10. The subject of the study were the linear hexamethyl disiloxanes, HMDS, and cyclic octamethyl cyclotetrasiloxane, which are ingredients of the dermal medicinal product and personal care products and cosmetics designed not only adults and children, but also infants. The aim of the study was assessment of skin barrier for HMDS, OMCTS, determination the depth of limit permeation through different layers of the skin, stratum corneum, epidermis, dermis to fluid acceptor, and observation of interaction, silicon corneal site and silicon lipid matrix. Study, the front type diffusion cells were used and human skin was taken from corpse. Fluid acceptor, from the top of the skin, silicons as a test samples and water as a control sample were dosed. Fluid acceptor had a contact with skin from underneath, and fluid acceptor was a model of blood and lymphatic vessels. The experience lasted for 24 hours. In study, two methods were used: attenuated total reflectance, Fourier transform infrared spectroscopy, and fluorescence microscopy. We characteristic and OMCT number 1404, 1259, 1059. It was found that this area didn't interfere with the skin matrix. Furthermore, fractionation by tape stripping of stratum corneum layers, 4 layer, 10 layer, enabled to the assessment of the depth of penetration through stratum corneum. An important result was also a demonstration of the polysiloxane in dermis, which provided evidence of permission of silicons through deeper skin layer. To observe the microscopic image, the skin sample was stained with the following fluorescent dyes: fluorescein, sulforodamine B, hexyl ester B. Fluorescein and sulforodamine B have a polar, hydrophilic, lipophobic properties and affinity to corneum protein. Polar, hydrophobic, lipophilic properties, affinity to lipids. Based on comparison of samples after application water and TS, it's observed that the structure corneum is disordered. On the slide, there is visible black spaces that confirm the destruction of the stratum corneum. In the case of OMCTS, the observations were similar. Stained samples by lipophilic dye, which was hexyl ester rhodamine B, provided evidence to establish the route of entry into the stratum corneum by silicons. Lipid matrix was intensely stained in the samples after application low molecular silicons. It was evidence that HMDS and OMCTS penetrate the skin by intercellular lipid pathway. Moreover, the deformation of corneal site was observed. They lost natural hexagonal or pentagonal shape. Three-dimensional images were the confirmation of this entry route. Also provided evidence of action by silicon corneum lipids. Stratum lipids matrix are destroyed, we can human skin for low molecular silicon, HMD demonstrated ability to penetrate the stratum corneum as well to permeate to the dermis where blood and lymphatic vessels are located. It has been shown that HMDS and OMCTS penetrate the stratum corneum by intercellular lipid pathway. Fluorescence microscopy provides basic information about the interaction between low molecular silicons, linear and cyclic, and lipid structure of the stratum corneum. What are the consequences of overcoming the skin barrier by low molecular cyclic and linear methyl siloxane silicons? The entry to human organism of silicons can result to uncontrolled their migration. Therefore, it's necessary to carry out research. The damage of the stratum corneum as a skin barrier may cause an easier entry of microorganisms, allergens, various substances from environment. Therefore, it's necessary to carry out research. The damage of the stratum corneum can by the larger substances from the medicinal and cosmetic products, which can be harmful. Therefore, it's necessary to carry out research. Thank you for attention. I'm sorry, but my English is not advanced. Therefore, if you wish to ask some question, please after presentation in foyer or by email. Sorry.
Thank you, Doctora. Any question for the Doctora? No?
Yeah, good afternoon, everybody. Thank you very much. I would like to share with you our experience in our results on initiation of antiretroviral in patients with skin complaint. I'll take you through a few abbreviations. KCMC is a Kilimanjaro Christian Medical Center. Where I'm coming is a Regional Dermatology Training Center. This is a center where it trains dermatologists from Eastern Central Africa. ART, antiretroviral therapy, HIV, infectious virus, and RLS. This is a resource-limited. So as you saw, my title was actually to analyze and to find out the effect of ARV manifestation HIV in. As you all know that 90% of patients with HIV at one stage will present with skin disease at a certain point of their disease progression. And that spectrum will vary from bacterial, virus, dermatophyte, other fungal infection, and also malignant, such as Kaposi sarcoma. Also, these patients tend to present with a atypical presentation in terms of maybe severity, long progression, and unresponsive to conventional therapy. HIV-associated skin manifestation is associated with low CD4 count. But there is a high concentration of CD4 count in the cell, in the skin of the human. So this is actually explaining, as what we have seen previous this morning regarding the psoriasis, that there is a lot of the T lymphocyte, macrophages, Langerhans cell, which are surveying the skin. And this will actually give us information of what is happening inside the body. So the importance of skin in immunopathogenesis and clinical presentation of HIV infection is explained by all that phenomena. The spectrum may differ between rich and resource-limited setting. As you may know that in Africa, the availability of ARV and initiation is a problem. So as the guideline, you know that WHO has a guideline of starting ARV. And the problem here is our guideline, it's either stage 4, AIDS-defining illness, stage 3, CD4 300, which show progression to disease, and CD4 below 200 regardless of any complication. So if you actually start a treatment with CD4 of 200, the immune system is already too low to back up with the opportunistic infection you have. So a majority who need antiretroviral therapy are in resource-limited setting. So this is a major problem. So what are the cutaneous response to antiretroviral therapy? As you all know that Uganda was one of the East African countries which was hit badly by HIV, and upon the initiation of ARVs, it shows a significant improvement on cutaneous manifestation. However, adverse reactions were also seen in this patient, whereby rash were seen in 20% of those patients. Also, drug reaction to sulfur is what we have seen this morning. At least 6% of those patients who were treated with cotrimoxazole develop a drug reaction. Iris. Iris was also a immune reconstitutive syndrome. Is also a manifestation which manifests in cutaneously, whereby when you start the antiretrovirus CD100, the immune system is not capable enough to mount, to detect anything. By then, when you start the ARVs, now the immune system is able to pick up all this disease and it's manifesting in the skin. So the main objective of our study was to address the gap in knowledge regarding the initiation of ART in resource-limited setting, whereby we wanted to see whether when we started the ART, there was effect in cutaneous manifestation. Material method. So we enrolled 100 patients who were infected with HIV with cutaneous complaint. These patients were recruited in Kilimanjaro Christian Medical Center as well as Mawenzi Regional Hospital, whereby the infectious clinic were located. The study was approved by Kilimanjaro Christian Medical Research's Ethical Committee, and eligible criteria for ARV was the patient was supposed to be seroconverted with a rapid test, antibody test, whereby we used the capillars and capillars test and Western blot. And they were supposed to be age of above 18 because we have pediatric HIV clinic, so we didn't want to involve them. And also they were supposed to have skin manifestation for HIV. And they were supposed to comply or to meet the criteria which were set by Ministry of Health guideline for initiation of ART. Data collection. The careful history was taken and was put in the standardized questionnaire. A subjective Rickett scale questionnaire was formulated, whereby this Rickett scale comprised of indicators which shows improvement to the patient, whereby we had plasma viral load, CD4, Burn scale, a photograph movement or West disease scale performance. Also were used who were recruited in the study. Blood sample were taken to assess the plasma viral load, CD4 level, and digital photograph were done during the baseline, first visit, third visit, and second and third visit, whereby these patients were followed first month, third month, and 6th month. All subjects started a fixed dose of combination of stavudine, lamivudine, and nevirapine. A dose for 2 weeks. Usually we start them with the starter pack to see whether any reaction. If any reaction appears, nevirapine rash, this patient, nevirapine is changed to efavirenz. Or if they have anemia, then stavudine is changed to zidovudine. Also, they were given cotrimoxazole as a prophylaxis for malaria and GIT infections. So the baseline characteristic of our study was the sex, Female were predominant, 59. Mean age was 37. Median CD4 was 120. PVL, plasma RNA, was 5.2. Most commonly, dermatological manifestation we saw was pruritic papular eruption, 47%. Eczema was 13%. Pruritus was 9%. Cirrhosis was 7%. And tinea was 5%. This graph shows a comparison of CD4 cell count versus PVL from baseline to third follow-up. As you can see, in baseline, the CD4 was up, and the PVL was very high. Sorry, the PVL was very high, the baseline. After a first visit, this is 1 month after initiation treatment, it was already down, followed to the second visit and consequently a third visit. This is the same applied to CD4. As you can see, baseline low. First, it was already starting to climb. Second visit, I can visit. This is a trend of mean band scale from baseline to third visit. We use a band scale to assess the extent of the skin area involved in the cutaneous manifestation of HIV, whereby, as you can see from the baseline with 38.3, by the time we reach 6 months of treatment, it was already dropped to 6.7. So there was a significant improvement with initiation of ARVs. Here you can see a chart showing a plasma viral load copies, which our machine, which we used, was able to detect until could detect below 75 only. We could not go below 75. But as you can see, the first visit after initiation of treatment was 29. Second visit was 90, and third visit was 99. If we go to CD4, first visit, this is the second visit, only 18, had more than 400 copies, and third visit already 84, had 400. So also, as I mentioned, that there were photo documentation to show improvement or worsening of the condition during ARV treatment. So this is one of the patients who had granulomatous candidiasis. This was during baseline, second visit, and third visit. So discussion. Skin showed to be a good indicator of immunological health, as all we have regarded the cytokines and the lymphocyte macrophage which surveil the skin. we were able to have 10 patients who had complete resolution of skin disease, skin complaint after initiation of ARV. There were decrease in Band scale score from medium of 38 to 7 over the 6 blood marker CD4 cell plasma HIV RNA level improved dramatically, as you saw from the start, from the baseline to 6 months of treatment. PPE, pruritic purpura eruption, was the most common finding in our study. And probably this is because that PPE is a disease which is seen in a very low CD4. And due to limited resource setting, availability of ARV, patients tend to start a treatment with a very low CD4. So this is a skin disease which is seen in low CD4 compared to Europe, whereby the guideline for starting ARV is quite different. From 500 you can start, so you don't get to manifest with PPE. Late presentation was common in our setting because of availability of ARVs, investigation, because we have to have the baseline investigation before. Improvement was not confined to single dermatosis, so we saw multiple improvement in different skin complaint. There was increase in that score. The fixed dose combination has outstanding response as seen in other studies in resource-limited setting. Inability to demonstrate a relationship between improvement in skin finding and the magnitude of CD4 cell count increase was difficult to measure. Probably this was because of difference between peripheral blood and cutaneous compartment, complex balance of immunological recoveries, immune reconstitution syndrome in skin, and probably the small sample size we had. Adverse drug reaction was uncommon, dispersals and vera, which was also stated in sulfur, in which in similar studies 20% of patients who started ART presented with nevirapine rash. 2 subjects died, different from other. 2 subjects died, and which is different from other studies, which showed 7.5 in 1 year. Rather than normal. In conclusion, it was clear to us that improvement in skin abnormality among HIV infected was benefited very much on initiation of antiretroviral treatment. Should be considered, ART should be considered the promise intervention. Thank you very much.
Thank you for inviting me, and I no conflict of interest. I'm a dermatologist, and I work with onychomycosis since 2011. And as my interest in this area, I work with Thaisa Villa and Sonia Rosenthal that works in a biophysical institute of molecular fungi to study how use the laser light to improve the onychomycosis. Onychomycosis is a nail infection caused by dermatophytes, yeast, or non-dermatophyte molds. It can cause nail plate discoloration. It also poses a risk of infection secondary site in the body. Several onychomycosis may present at the severe subungual as to total dystrophic onychomycosis. It's critical to treat onychomycosis for both medical and cosmetic purposes. The incidence of onychomycosis is higher in elderly patients and patients with diabetes, peripheral vascular diseases, HIV, immunosuppression, obesity, and smoking. Even when initial therapy is successful at a complete or mycological cure, it's a higher rate of relapse and recurrence due to the presence of fungal material in the patient environment. The relapse may be due to the presence of drug-resistant arthoconidia in the nail plates, as well as Ziphi with germinate, and often becomes a chronic condition with disease durations in the range of several years. The need for no-invasive, safe, and effective therapy alternative to treat onychomycosis has led to testing of lasers and light-based treatment. Although the exact mechanism of laser and light therapy is still under investigation, it may continue to direct fungicidal effects with local immune system modification, named photoinactivation and photoimmunomodulation. Previous studies have shown that near-infrared application at physiological temperatures lead to photoinactivation of Staphylococcus aureus, Escherichia coli, Candida albicans, and Trichophthora rubrum, by changing the potential across the cell membranes and increase of the level of reactive oxygen species. Light for systems and treatment of onychomycosis has been demonstrated in clinical trials in viral studies. In clinical trials, neodymium laser treatment led to 87 to 51 of negative cultures of 1 to 3 sections of treatment, while near-infrared treatment led 100% of negative cultures and was effective against mild, moderate, and severe cases of onychomycosis. Local application of blue light, IPL 420 nanometers, has been described as a successful treatment for acne. However, no clinical or in vitro study has demonstrated the use of IPL 420 in treatment of nail fungal infections. Despite of available evidence for efficacy of several laser light use in treatment of onychomycosis, the FDA has approved the use of laser systems only for the increase of clear nails in onychomycosis, since the basically in the extracellular matrix and contain dormant fungal elements. This led to a recent debate on whether onychomycosis lesion should be considered biofilms. Several factors include the firm adherence of dermatophyte to the nail place, presence of the dormant fungal elements, inability to yeast to form biofilms, and difficulty to infection eradication suggests that biofilms are likely to be an important factor in onychomycosis pathogenesis. Given the lack of suitable in vitro methods to test the fungicidal potential and laser and light treatments, and the importance of the biofilm formation in onychomycosis, the aim of this work was examine the potential of a new in vitro model of fungal biofilms developed in human nail fragments for evaluation of fungicidal activity for 4 different laser or light treatments. Neodymium 1064, IPL 420, near infrared, and combined application IPL follow laser. Fusarium oxysporum was chosen as a model for this study because in the vitro biofilm formation by this species is well established in our laboratory, and also this species was particularly relevant onychomycosis pathogen in Brazil, where the study was performed. Since the frequency of use of footwear exposes the feature fungi found in the soil, such as Fusarium oxysporum, while the common practice of manicure with complete cuticle removal exposes nails to Candida albicans infections and bacteria. Microorganisms. Candida albicans and Fusarium oxysporum reference strains were used in this study. Both strains were maintained in Sabouraud-Destroz agar at 4 centigrade degree, and this stock were kept for no longer than 30 days. Prior to the use of experiments, Fusarium oxysporum was subcultured on Sabouraud-Destroz agar for 10 days at 28 centigrade degree. And Candida albicans was subcultured on Sabouraud-Destroz broth for 24 hours at 35 centigrade degree. Fingernail fragments were acceptably collected with healthy females volunteers with no fungal infection history, cut in a small and prior to use. Biofilm to the inner surface of sterile section of a human nail placed inside a well of polystyrene plates. Aliquots of cell suspensions with Candida albicans yeast or Fusarium oxysporum conidia were transferred into each well-contained nail fragments, and plates were incubated for 90 minutes at 36 centigrade degree, and the constant agitation. Instances were gently aspirated, supplement with 2% glucose in serum, 48 hours for Fusarium oxysporum at 36 degree, and constant agitation with fragments, the entire fragment surface with cover with Candida albicans biofilms. The typical Candida albicans biofilms structures could be observed with complex network in the interconnected hyphae and numerous buds. During in vitro development, biofilms, Fusarium oxysporum conidia converted to mycelia, forming filamentous biofilms. Nail contains immature biofilms which to one or following laser or light treatments. Neodymium laser, IPL, combination IPL and neodymium laser, near infrared by Joule Equipment from Cyton Company. Control snail with mature biofilms were maintained at 96 well plate. The neodymium laser was used with a pulse duration of 0.3 milliseconds at low energy, 5 to 7. This energy was found because when you use the 1 to 10 joules, it's possible to be a biological effect without a very strong hit. And the frequency of as a 6 by circular movements to avoid stacking. Temperature not exceed 44 centigrade degree. IPL was applied with a 420 nanometers filter with a small circular adapters. Nail subjects to 256 pulses at 200 milliseconds each at low energy, 8 joules per centimeter per square. The final temperature was determined to use infrared. The combined use of IPL and neodymium laser used the same parameters described before. Near infrared was used 150 joules per centimeter per square with a pulse duration at 12 milliseconds, and nail subjects at 27 pulses, and the temperature during the light application was monitored manually with infrared thermometer and was maintained between 40 and 43 degrees. Nail section contained the biofilm were processed at scanning electron microscopy. Nails were washed with a phosphate buffer saline and fixed for 1 hour at room temperature in 2.5% glutaraldehyde and 4 formaldehyde cacoylate buffer. Then nails were washed in the same buffer, post-fixed at 1% osmium tetroxide on ferrocyanide 2 hours, and dehydrated in a series of ethanol concentrations for 30 minutes. Samples were critically point dried at CO2, coated with gold, and observed in scanning electron microscopy. Candida nails after laser or light treatments, we no observe relevant alteration that surface and in this biofilm with laser or light treatment. Analyze the fusarium oxide, we were highly effective against these fungal biofilms. Unlike the untreated Candida albicans biofilm, which lacked a clearly visible extracellular matrix when observed by electronic amount of extracellular matrix were observed around the cells of Fusarium oxysporum untreated control biofilms. Extracellular matrix also appeared to cover Fusarium oxysporum cells after IPL treatment. After treatment after neodymium 1064 or near infrared, display a hole on the surface and subject of intracellular material. Cell surface damaged also apparent tree, while near to large cell buds. Now we analyze the biofilm cell viability assay. After laser and light application, nail-contained biofilms were transferred to a micro centrifuge tubes containing phosphate buffer saline, and these biofilms were disrupted by sonication, followed by vortexing. An aliquot of the suspension containing the biofilm disrupted cells was plated in a fresh subwhole dextrose agar for 48 hours at 35 centigrade degree for Candida albicans, or at 28 centigrade degree for Fusarium oxysporum. Candida albicans samples were diluted in a phosphate buffer saline prior to plating. The number of colonies formed after combination was determined by manual counting, and the biofilm cell viability was expressed of biofilm suspension. Now the results with Candida albicans. Plating of biofilm cells after treatment showing that all the treatment tests to lead to decrease in the biofilm cell viability. When you saw an electronic microscopy, we don't see any alteration, but of 50% of regrowing the Candida albicans. Also, an application of IGA 1064 laser after IPL RESIDUA. And although the combination of IPL with neodymium was effective as 1064 alone, resulted in a decrease of 52 cell viability. An important to lesser decrease in biofilm cell viability was obtained after near infrared application, with 60%. A neodymium laser 1064 and IPL used alone or in combination were highly effective against sporon biofilms, lead to a complete elimination of viable cells within biofilms. Near-infrared was slightly less effective than 1064 and IPL, but still show a considerable degrees, 92% in number of viable biofilm cells. In conclusion, we show that biofilms of pathogenic cancer and Fusarium oxysporum form in vitro human nail fragments was susceptible to both a 1064 laser alone or in combination and IPL 420, and also a near-infrared treatment. All findings highlight the potential of the in vitro model using in fungal biofilms format and human nail fragments to test the fungicidal efficacy of laser and light treatments, both or in combination therapy. The model described could be used for standardization of laser and light parameters in the treatment of chronic onychomycosis, when conventional topical or chemical therapy has failed. All parameters used in this work were designed based on a report of patients' experience in the clinic. Mild discomfort and heat, but no pain with intermittent application, and the physiological temperature was respected. Thank you. This is Thais, and this pharmaceutic, and she developed a very interesting work in this area, and in the department of University of Rio de Janeiro. Thank you.
Who are the dermatologists here? Okay. I'm a plastic surgeon. This is my disclosure. Now, closing big gaps are always a challenge. We've been taught to use sutures for thousands of years. Egyptians were the first to use hair and bones suture. And again, changes in suturing techniques were just light.